Good day. I am Dr. Kaiserine Santos Lipana. I will deliver the lecture today on surgeon-performed ultrasound for the management of the breast. This lecture is part of your advanced course for the breast ultrasound. Later, during the hands-on workshop, you are to rotate at different stations, namely normal anatomy of the breast, a station with a live patient who has a suspicious breast lesion, and the two other stations for percutaneous procedures, the most useful and common, which are ultrasound-guided fine needle aspiration biopsy and ultrasound-guided core needle biopsy for the diagnosis of BI-RADS 4 and 5 lesions. To date, PISUS is in the process of revisiting, modifying, and refining the curriculum for surgeon-performed ultrasound for the breast, as well as other organ systems. We have, as a guide, already validated, readily available clinical practice guidelines, and you may use these also. For the breast, we have the official statement of the American Society of Breast Surgeons. We look to it for the following: how to perform ultrasound, how to acquire and hone our skills, and we will modify these guidelines to adapt to our local practice. Having already attended the basic course, you all have been made familiar with the different parts of the ultrasound machine and for each of the function. To review, here is a list of the ultrasound machine. The ultrasound uses high-frequency sound waves to create an image. This is a summary of the physics of sound. Transducer is the key. Piezoelectric crystals within the transducer convert electrical energy to mechanical energy after a voltage is applied across them. Mechanical energy acts as the generator of the ultrasound waves in layers of the breast. The transducer then listens to the returning vibration of sound waves as they bounce off different lesions and the surrounding breast tissue. The returning vibration deforms these cells, transforming the mechanical energy back to electrical energy. This current received by the transducer is analyzed by the ultrasound machine to generate the B mode. To produce the ultrasound images, the amplitude of the returning ultrasound waves are depicted as a function of brightness. Therefore, B mode. So the mode for breast is B. The use of the grayscale in these imaging renders the 2D pictures where the lesions and normal breast tissues are depicted as points of variable brightness. So, to use your ultrasound machine for breast imaging, use the high frequency, which is 7.5 to 15 millihertz. 2, the linear transducer. 3, split to T mode. And 4, adjusted depth of about 4 to 6 centimeters. With this depth, you will see all the different layers. To know what these layers are, we have to familiarize ourselves with the normal breast anatomy on ultrasound. We have to have the discipline to make sure we see all these layers as we perform the ultrasound at point of care. To train our eyes and the brain to see the different shades in the grayscale. So, from top to bottom, it's from skin, subcutaneous fat, the pre-mammary fascia, the breast tissue. This is the glandular organ. Actually, this is the area. If dilated, we will see prominent duct tissues or ductal dilatation. Then the retromammary zone. This is usually where we see the pectoralis fascia. And in some individuals, some prepectoral fat is seen here. And then we see the pectoralis muscle. On the left, If the depth of penetration is actually increased, the beating heart may be detected. After visualizing all the layers, usually we use ultrasound for the confirmation of already imaged lesions by our radio colleagues. And we also use ultrasound as our eyes during appropriate procedures such as percutaneous biopsies. These are ultrasound-guided fine needle aspiration biopsy or ultrasound-guided core needle biopsy. Also, to determine the appropriate management, whether observation or intervention, and if intervention, what type, we combine all the characteristics that we see of the images to arrive at BI-RADS. BI-RADS actually is the summary of all characteristics we see in the lesion to be able to classify whether they are benign, probably benign, suspicious for malignancy, or highly suspicious for malignancy. Memorize these characteristics and again have the discipline to check for all these as you view the ultrasound images. This table summarizes the characteristics or the lexicon for malignant and benign lesions. You can see on the left representative images. So when we talk about shape, for malignant, it's either irregular. For benign, it's oval or round. For the orientation, usually this is relative to the chest wall. For malignant, they are the ones that are taller than wide or they are vertical in line. For benign, they are parallel to the chest wall or the opposite, wider than tall. For margins, we look at if they are indistinct or if they are circumscribed or well-defined for benign. The margin contour may be irregular, angulated, or spiculated for malignant lesions. And for benign, they can be smooth or sometimes with gentle lobulations. Echogenicity is how they actually compare to the isoechoic fat. For malignant, they usually are hypoechoic. For benign lesions, they are ranged from either isoechoic to fat, hypoechoic, or hyperechoic even. For how different the tissues are within, it's either homogeneous or heterogeneous. Then we look at the posterior features. If they are with shadowing, they are mostly on the suspicious for malignant side. And if there are no changes or there are actually visible enhancement at the posterior area, they are benign. For calcifications, microcalcifications are not usually seen on ultrasound. So what we see are the benign macro, or these are the popcorn-like calcifications. And with the surrounding tissue, usually for malignant, there are architectural distortions or evidences of desmoplastic reaction in the form of sometimes halo. For benign, there usually are no alterations. BI-RADS stands for Breast Imaging Reporting and Data System. It is a tool established to standardize reporting and, as mentioned, to summarize, to have a universal language between sonologists, radiologists, and surgeons, to facilitate communication, diagnosis, and to determine the appropriate management for the identified lesion. You as clinicians can also use the BI-RADS to convey to the patient what lesion they have, and it's easier actually to narrow down to them and give them the options so they can either have an informed choice if they have a choice for observation or intervention, or if they do not have a choice, to understand the urgency to consent to unnecessary procedures, such as if it's BI-RADS 4 or 5, consent to the ultrasound-guided core needle biopsy. Most of the official ultrasound results already aid our diagnosis of a possible palpable or visible lesion or an area of interest because it is painful or there is some discomfort that the patient can feel. Often, we encounter patients with both mammogram and ultrasound already. When we look at the mammogram and we see a suspicious high-density lesion, biopsy is definitely easier if the lesion on mammogram corresponds to a lesion on ultrasound. Therefore, ultrasound-guided core needle biopsy can be done for diagnosis if this mammogram lesion actually corresponds to anything on ultrasound. Just a review, because our friends in radiology have already scanned both the breasts in its entirety, including the axilla. So this slide is only like a summary and a review. If we actually have a patient presenting with a palpable nodule or an area of interest because of pain or discomfort, ultrasound is done and either there will be no lesion, just prominent parenchyma, therefore BI-RADS 1 negative. Or there actually might be a lesion. The nodule may either be cystic, in which case BI-RADS 2, solid. If it is solid, then we look at all the characteristics present in that lesion and can be either BI-RADS 3, probably benign, or BI-RADS 4, there's a low suspicion for malignancy, or BI-RADS 5, highly suspicious for malignancy. Once we have a firm diagnosis, then we plan our management. As we plan our management, obviously using ultrasound when necessary. Again, here we have to have the discipline to adhere to the following principles of surgery. So the first principle of surgery, proper exposure. With the use of ultrasound during our percutaneous procedures, we will actually accurately visualize the lesion. And although some BI-RADS 4 or 5 lesions may be palpable, we still use the ultrasound to see exactly that we are sampling different parts of the lesion. I often tell my residents to sample top, middle, bottom. Then after they have taken samples from these areas, they can then take random samples elsewhere. This then decreases the sampling error. Also, second principle of surgery, handling the tissue with care. With direct visualization with ultrasound, we can minimize the chances of inadvertent like pneumothorax, for example, because on core needle biopsy, there is a 2-centimeter throw. With direct visualization, we know exactly where our needle will go, and this will help us maintain that the needle is maintained parallel to the chest wall. Direct visualization also allows less tissue manipulation, such as when we are doing the vacuum-assisted excision biopsy, we can see the lesion being vacuumed and excised in strips in real time. The principle, right tool for the right job. This is actually like using properly opposing clamps or using our sharp nets. Ultrasound also promotes accuracy. Only the target lesion is excised. Efficiency. It's easy to do the job if you can directly visualize what you have to excise. And for safety, as mentioned, direct visualization aids in inadvertent injuries. By maintaining our needles in the parallel to the chest wall and seeing the needle in its entirety from entry to the lesion to biopsy to pulling out the needle. The fourth principle, if it is not written, it was not done. This is why we encourage accurate optics. So for ultrasound, it is the proper documentation, meaning take photos of the target lesion during the procedure and post-procedure. I'll show this to you later. The next principle is be accurate and be updated. We have dynamic clinical practice guidelines as our practices are ever changing, ever evolving. So it is up to us to actually hone our skills, learn, and actually apply our new learning. The last principle, a picture paints 1,000 words. This is the emphasis for documentation and the mastery of the BI-RADS. The BIRADS actually will promote you reading your ultrasounds correctly, communicating these results, and looking for the proper management. Going now to our surgeon performed ultrasound during these procedures, we have these various procedures enumerated. They are all ultrasound guided. They are fine needle aspiration biopsy for cysts, core needle biopsy for BIRADS 4 and 5 lesions, core needle biopsy for suspicious looking axillary lymph nodes, intraoperative marking for our gross margins during our partial mastectomy, intraoperative marking of multicentric lesions during excision. It's ultrasound mapping, especially when we do our oncoplastic procedures to decrease tissue manipulation, and for our ultrasound guided wire localizations for very small lesions. Our surgeon performed ultrasound at the point of care aids us that we have better visualization, we are more accurate, we are more efficient. We actually decrease our sampling error, we decrease the risk of inadvertent injury, and we also decrease the tissue volume we excise, and we have better margin status. As mentioned, the advanced course this afternoon will have demonstration units on hands-on and a return demo with evaluation on the two widely used percutaneous procedures. It's our ultrasound-guided fine needle aspiration biopsy. It is actually mostly used for both diagnostic and therapeutic of our cystic nodules. The use of ultrasound and fine needle aspiration is for accurate placement of the needle. We visualize the gauge 18 upon entry as it punctures the cyst, and to document in real time the complete aspiration of the cystic content. Complete aspiration of cystic content decreases the rate of recurrence, as stated in a lot of retrospective studies. Next, I will play two videos for the second percutaneous procedure offered in this advanced course, which is ultrasound-guided core needle biopsy for BIRADS 4 and 5 lesions. As mentioned, the core needle has a standard of 2 centimeter throw as it samples. It is important to emphasize the needle visualization at all times. As your needle enters the breast tissue, as you approach your target lesion, and as you fire to get sample tissues. We must maintain the needle to be parallel to the chest wall at all times, and to keep the target lesion at the center of your screen, to continue to visualize the entire needle as it goes through the lesion as well as the surrounding tissue. There is a brand of needle. I am not promoting a specific brand. It's just that this Achieve needle came up with two settings. One setting is the standard with a 2 centimeter throw, and the other convenient setting is that the needle upon entry is already half deployed, exposing the aperture of the sampling part of the needle. Instead of a 2 centimeter allowance, we can actually insert the entire needle, visualizing the aperture within the target lesion. And when we deploy for sample, it no longer gives the 2 centimeter throw, except that the blade cuts into the target lesion and the same strip of sample is achieved. No? This emphasizes our direct visualization of that aperture in the sampling. One very important use of our ultrasound is documentation. We have to image our target lesion. We have to visualize our needle, whether we are infiltrating for a local anesthesia or during the procedure. And we actually have to visualize the entire procedure where our needle is parallel always to the chest wall, and even as we withdraw the needle. We also have to take a photo post core needle biopsy or any post procedure to document the area sampled. These areas will have different grayscale, like so in the third photo, as well as to check for possible developing hematoma. In a study by Dillon et al., they wanted to check the accuracy of ultrasound-guided core needle biopsy. So with their 2,000 plus core needle biopsy results over the 5-year period, they saw that the overall false negative rate was 6.1%. When they tweaked it out in the different imaging modalities, ultrasound is one, stereotactic is another, and no image guidance was another. They found that ultrasound guided false negative rate was 1.7% only, as against the others that were 8.9 for stereotactic guidance, and with no image guidance at all, it was 13%. So the use of ultrasound decreases false negative rate significantly. To further decrease false negative rates, even on palpable lesions, especially on lesions accompanied by skin thickening and Pio de Orange changes, the use of ultrasound during core needle biopsy again visualizes the target lesion, and these areas are sampled better, and we avoid sampling the surrounding tissue, edematous tissue, or with desmoplastic reaction. And not all lesions will be this shallow as the one seen at the bottom picture. Some may actually have some distance from the actual palpable thickened skin. The rest of my slides are actually just an enumeration and surface elaboration for the many different uses of ultrasound in our practice for breast management. For suspicious axillary lymph node, we actually can sample this using ultrasound-guided core needle biopsy with the aid of Doppler, because the axillary area is actually a very vascular area, and we have the large axillary vein there. Ultrasound with Doppler is very useful in these cases. It is also used for the proper placement of marker for the sampled node, especially if the patient is for neoadjuvant chemotherapy or targeted therapy, and hopefully she responds. She may even be a candidate for sentinel lymph node with a clip node sampled and harvested. Identification and localization for very small lesions which cannot be palpable but actually need to be excised, we use ultrasound. Occasionally, we just mark during the point of excision, or sometimes we actually deploy needle to localize this lesion under ultrasound guidance. After excision, we can then take ex vivo ultrasound photos to document the excision of said non-palpable lesions. Another use for ultrasound is during our vacuum-assisted excision biopsy. Ultrasound is very useful for documentation of proper placement of the probe prior to initiating the vacuum excision. Second, also, it's the intra-op assessment that the number of cores will approximately correspond to the size of the lesion, and also the direct visualization of complete excision. Ultrasound-guided wire localization for lesions that we cannot palpate. The ultrasound is used to guide the needle to target the lesion before we deploy the wire. The ultrasound is subsequently used to mark the gross margins of 1 centimeter usually around the target lesions for our partial mastectomy. For this procedure, accuracy to excise the target lesion and to have a higher chance of negative margins with less volume of tissue excised is the use of our ultrasound in vivo and then the ex vivo documentation of our excised target lesion. This is an actual patient. I used an ultrasound to localize that very small lesion on the ultrasound photo. We also had markings for the margins for our partial mastectomy, and that is the small volume of tissue excised, sent for frozen section, and the margins were all negative. With a small volume of breast, but we were able to remove a smaller volume of tissue. We're able to achieve partial mastectomy, and aesthetic was still maintained. And then the patient was also a candidate for intraoperative radiotherapy. Now, the intra-op use of ultrasound also helped the determination of the appropriate applicator size for the intraoperative radiotherapy. For lesions not necessarily malignant, but also for benign lesions, if they are scattered all over the breast, multicentric, and we wish to excise them with minimal tissue manipulation and less volume of tissue. Ultrasound is used to map out where these exact lesions are, and so we can plan the proper oncoplastic procedure. Like for this patient with multiple fibroadenoma in different locations, multicentric, we used the following markers. We provided the map so that we were able to perform oncoplastic procedure. Only the target lesions were removed, minimal tissue manipulation, and this is the post-op picture of a very happy patient. For this patient, on diagnostic ultrasound she was very young, nulliparous with bloody nipple discharge from a single duct. It was identified that there was a nodule within a dilated duct. So during microdocectomy, once the probe was inside, we used the ultrasound to confirm if the probe from outside was contiguous with a dilated duct, and if this is the duct within which the target nodule was located. We were able to confirm this, and on a nulliparous female still desirous of pregnancy and breastfeeding, It was very important to only excise the target duct with a lesion, and it was achieved microdocectomy under ultrasound guidance. My last few slides actually are no longer at point of use, but this is actually two important times when we surgeons have to pay attention to the ultrasound results of our patient. One is during the treatment of invasive breast cancer and they are undergoing neoadjuvant chemotherapy and targeted therapy. Ultrasound will document their response to treatment, and ultrasound will also help us plan our surgery. If these patients have lesions that responded well enough, if they can still be offered breast conserving therapy, in which case we plan partial mastectomy with gross margins. Surgical planning for the axillary lymph node, if during the neoadjuvant chemotherapy, did these nodes respond? So such that these patients can be offered sentinel lymph node biopsy with harvesting of those marked nodes using ultrasound guidance pre-neoadjuvant. The utility of ultrasound is also for our post-operative continuity of care, for surveillance of our post-mastectomy patients, their anterior chest, their ipsilateral axillary lymph node, contralateral breast, and contralateral axillary lymph node, also with an emphasis that this contralateral side will also need mammogram. Also, surveillance post-breast conserving therapy, especially that architectural distortion should remain as a distortion and no other lesion growing in that area. Surveillance post-immediate reconstruction also to check our saline silicone implants or even the autologous implants should the need arise. And also surveillance of implants post-reconstruction. It is important that we also view several images that we know when there are abnormalities in these reconstructed breasts. So those are actually the function of point of care ultrasound for breast for us surgeons, and I'll be happy to answer questions during our live session. And we will actually have demo, hands-on, and return demo with evaluation at the stations during this afternoon's workshop. Thank you again.